Hi, good morning, everyone, and welcome to Global Neuroscience's Grand Rounds for December 5th. I'm very pleased to introduce our speaker. On a personal note, he was one of our favorite fellows of all time who came through the Cerebrovascular Fellowship at GNI, Dr. Daniel Feldbaum. We know him as Rocky. He, as I said, is trained in cerebrovascular, both open and endovascular neurosurgery. He is part of the team of neurosurgeons at MedStar Washington Hospital Center and MedStar Georgetown University Hospital, and dedicated to creating individualized treatment plans for each patient and to deliver collaborative care. He received his medical degree from Marshall University School of Medicine, where he was inducted in the Alpha Omega Alpha Honor Medical Society. He then joined MedStar Georgetown for a 6-year residency in neurosurgery before completing our specialty here with Global Neurosciences. He presents nationally on numerous occasions and has been published in several peer-reviewed publications and book chapters on cerebrovascular neurosurgery and trauma. He's passionate about providing stroke management and treatment, as well as neuroendovascular surgery options to patients in Washington, D.C., and he and his team are implementing an interventional treatment strategy for strokes and focus on improving outcomes for stroke patients. Today, he's going to be talking about really his grassroots effort to start a global neurosurgery outreach. And I think that I got a little preview of this at the SUNS meeting, and I can't wait to hear more about your outreach and the lessons learned.
Great. Thank you for the kind introduction. Really excited to be back to see you guys again. I really owe a lot to my time being with you guys. I'm going to start sharing my screen and get going. Somehow, as I've gotten older, Dr. Liebman, Vez, and Dr. Benning don't look like they've aged whatsoever. So I'm going to be talking about global neurosurgery. Really, this is something I've stumbled upon. It's not something I grew up wanting to do. It's just something that's happened organically. I've been doing it with my former co-resident. So Dr. Nazi, who's also here at Georgetown, Dr. Syed, who's at Children's National, pediatric neurosurgeon, and Dr. Jean, who's really the person that started all of this. Just want to make sure that everybody can see my screen. Yes?
Yeah, we can see it.
Okay, so part of the list that I was asked to talk about objective is what is global neurosurgery? It seems to be like this catch-all term, sort of this, what does this actually mean? So traditionally, global neurosurgery was you do a bunch of operations, you go to some country where they don't have neurosurgery, you do surgeries for about a week or so, and then you kind of leave. And then it became this sort of thing of who manages these complications afterwards. Do these places have rehab? And what I've learned as I've gone to these various countries, like, what's the ICU support? Where do they go? What's the anesthesia like? And then it becomes a question like, what if you found somebody that you thought was very talented, and then you trained them in the U.S.? Does that help them? Does that help the country when they go back? Do you train people to do a specific operation over there? How about setting up rotations where you either go over there to the other country, or do you bring them over here? So there's been a big push of global neurosurgery and organized neurosurgery probably over the last couple of years that I'll kind of show. These are some of the articles that have been published recently, and hopefully we'll learn a little bit more about global neurosurgery from both a big organized neurosurgery perspective and from the small guys perspective. So basically, one of the existential questions is, what is neurosurgery? How do we exist? And so a lot of that depends on things like EMS. Do you have an emergency care system that will allow these patients with neurologic injuries to be taken to the hospital? You have imaging then to be able to be provided for these patients. And then is there actually a specialist that can take care of these patients? But so that first article I showed is talking about the big need for EMS or emergency care services. And having that increased development in other countries. And you know that starts from a government level, right? Much more so than an individualized level. And so basically that article is talking about how helmets and seatbelts are much, much more efficacious in neurosurgical, neurological injuries than being able to perform a craniotomy. Same thing, good healthcare, blood pressure control, early access to primary care, that can beat any thrombectomy that we can do, any craniectomy we can do for an ICH, or any clipping or equivalent that we can do for an aneurysm. And these are the sort of the benchmark guidelines they're trying to implement on a global standstill. I think it might be a little bit of a stretch as I go through my experiences from the different countries, but I think these are good benchmarks to have where the EMS is trained in neuro care. Dr. Key Park at Harvard has really been the big figurehead for global neurosurgery. There's a bunch of Seattle Science Foundation talks on this, and they're pretty interesting talks on how he's trying to change culture. How do we change the culture of the group of neurosurgery residents in the U.S., faculty in the U.S., to kind of incorporate a more global understanding of neurosurgery? And so that's really what he's trying to push through with his experiences at Harvard. There's a lot of organized neurosurgery that's really pushing this. There are lots of talks, articles, and thought processes that are trying to push global neurosurgery. And in almost every meeting that we have nowadays, AANS, CNS, WFNIS, PEANS, there's committees, subcommittees, and most months you'll see an article published about global neurosurgery. So there's a bigger understanding, there's a bigger push, and there's a bigger awareness about this. But then from the biggest, probably most ideal perspective, there's the Duke Global Neurosurgery that exists. Cornell has a very big one for Tanzania. I think UAB also has a very big program. Those are probably the biggest programs. And this is what Duke's published on their experience. And they talk about the 3 T's: technology, twinning, and training. And so basically they've been able to start over the period of 15 to 20 years. They've now created a freestanding neuroscience institute in Uganda. But this is what they're talking about. Neurosurgery sort of is so dependent on basic emergency transport. So starting off with an ambulance. Is there an ambulance available? Will that ambulance then take you to a hospital? When you get to the hospital or emergency room, do they have a CAT scan? In the US, these things are sort of, they're everywhere. But in other countries, they may not have an ambulance and they may not have a CAT scan. Who's going to pay for that CAT scan? Is it the patient who then has to struggle, figure out cash before they can get the CAT scan? And then what are you going to do with that information when you do have the CAT scan, right? If you have a subdural or then able to afford surgery, is there someone that can do surgery? Is it a single payer government system or is it a private pay system? So all of these things need to be aligned before even the neurosurgeons involved. And so that's part of the difficulty of global neurosurgery once you go to different countries. There are a lot of things that we take for granted that is so ubiquitous here in the US. So part of their what they started doing at Uganda is they brought technology. So working high-speed drill bits, having working bipolars. Once you got that down, can you have light access? Can you get a CT scan, an MRI? Later on, can you bring navigation and then a microscope? So those are higher, more expensive things that you can bring with you. The things that you do in Duke, can you do that in Uganda for certain tumors? So that's the twinning component of it. Trying to reciprocate what works in the US, can that work in a different country? And then really the big focus in global neurosurgery is, can you train the local residencies, local surgeons to become competent, good neurosurgeons that can take care of patients without needing that U.S. training, U.S. governance kind of watching over them. And then ultimately, like I said, if you see this idea out into its biggest fruition, its biggest deal, then you have a freestanding neuroscience institute, which they have. So they have their own neuro ICU, own neurosurgeons. They now have residencies from other countries in Africa that come to Uganda to get their training. So that's probably, from a standpoint for me, that this is probably the ideal place if we do see out global neurosurgery to its largest fruition. This is a little bit more interesting concept. So at the recent AANS meeting in Boston, there was a big emphasis on global neurosurgery. And this is one of the things that they talked about is building an AVM program in Paraguay. So basically the neurosurgeons in Paraguay said, hey, they went up to the guys at Beth Israel and Harvard and MGH and said, hey, we want to be able to do AVM surgery. can you help us? And so the way they have described it is they say, okay, so you have an AVM, then can you do a CT angiogram? We think we can do that anywhere here in the US, but can you do a CT angiogram in Paraguay? Yes. Can you do an angiogram? Can you do an embolization plus the angiogram? And then if you're going to resect, do you have working bipolars? Do you have AVM clips? Do you have microscope? And how many AVMs do you think you need to do independently before you can say you can take one out appropriately and understand the angiogram and the high risk features? And so they basically reverse engineered what they did here in the US and then brought it over there. And so they essentially had a curriculum to do 4 to 5 AVMs a year. So there was a team that came once or twice a year, neuroanesthesia, neuroradiologist, neurosurgeon. And they brought in all the materials, and then basically over 5 years, they were able to train their Paraguayan counterparts to do AVM surgery. And the sidebar to that is since they got confident and competent in dealing with AVMs, they were then able to do more and more aneurysm surgery. So that was a wonderful byproduct of being more comfortable with AVMs. And then it helps really build local expertise. And then other countries are now sending their patients to you to take care of the AVMs. And then it kind of expands even more. This is Dr. Aldana and his wife with a bunch of, this is Dr. Hanel. This is probably something that is more attainable for someone like me. He's a Filipino neurosurgeon, did his training in Florida. He's in Miami Baptist. He's a pediatric neurosurgeon. He's been going to the Philippines, I think, for the last decade or so. And then more recently, as he's been able to come up with a website and all the paperwork that comes with forming an organization with a board of directors, he then has had a contract, I believe, with the World Health Organization. He's been going to Mongolia once or twice a year to do pediatric neurosurgery. So he's doing 2 trips a year, or at least 1 trip a year, doing global neurosurgery. So it's very not heady, but heavy education. How can you train the local guys, endoscopic third ventriculostomies, trying to avoid shunts because we know shunts tend to have a high rate of failure. Can we do ETVs? Can we push ETVs, the indications, cord plexus, cauterization, ETVs for these kids to try to avoid having to do permanent CSF diversion? So that's really what they're trying to emphasize when they do their medical mission trips. I think this is probably the most reasonable, at least for someone like me, to try to attain moving forward with this idea and concept. So this is us. This is me and my former co-residents that are all faculty now. And then how did we kind of wind up in this situation where we're going to Africa once, twice a year and trying to do these type of surgeries? And it's all really been chance meetings. This was my mentor, Dr. Jean. He was at Georgetown, then GW. He had a very big social media presence, and basically someone said, hey, would you ever go to Vietnam? So that's sort of where we started. Just right before COVID, we went to Vietnam for a meeting. I think this was 2019, 2018, something like that. And then fortunately at Georgetown, we have some pretty amazing medical students. One is Kojo over here to the right. He's got a wonderful Medscape story. I can't stop talking about him. Basically got a lottery ticket to the U.S., was working as a custodian. Someone took interest into him because he was cleaning up at in Emory in Atlanta. I said, hey, why don't you go to medical school? Got his all the pre-medical requisites, then wound up matching at Georgetown for his medical school. And then one day he just came up to me and said, hey, would you ever go to Ghana? And then he introduced me to this gentleman over here in the middle, Dr. Tatame, Dr. T or Teddy. And then just with these conversations, we're able to come up with a medical mission trip. We've been going there for the last 3 or 4 years now. And that's really what sort of kept me going in this global neurosurgery. It was all chance, all luck. So this is sort of what we stumbled into. So this is 2019, just out of my fellowship at JNI with everybody. Hey, let's go to a different country to do a surgery that we don't do a whole lot of in the US anymore. And this is sort of the first case they handed to me. Fortunately, we planned ahead of time. They did have a microscope. They didn't really have any AVM clips, so this was going to be mostly a bipolar type thing. But it takes something. It was challenging for me because I'm so used to scrolling through films on a computer to going to hard films. Usually I work backwards, find the vein, find the nidus, find the artery, which is a little bit trickier in hard film. So it's a skill set I think that is being lost now that everything's sort of digitized. This was the case they handed to me. Ruptured, been in the hospital for a couple of days, big clot, big AVM. There's no pre-op embo. This is the angiogram that I got. Would we take it out? And so this is the case that we did. It was a little harrying, taking out a full AVM without embolization because I'm so used to doing preoperative embolization, but we were able to do this, and it really forces growth. Part of the thing is you learn in Vietnam, the training is so varied, even within the hospitals, within the same city or within the same country. But because of its ties, a lot of their neurosurgeons will do subspecialty training in France, and they get very high-end training. And so what I put over here is training can be anywhere from 2 to 4 years. It's interesting that the country, what they really need are neurosurgeons that can do hemicranies for stroke, subdurals, chronic subdurals, acute subdurals, or epidurals, managing subdural empyemas, and doing shunt. And so that's why their training can be anywhere from 2 to 3 years. And then you can go out into the country and then be of service to the vast majority of the population that need neurosurgery issues with taking care of these type of problems. And then basically they get put on a prolonged path of mentorship and guidelines to be able to do the higher end operations, AVMs, bypasses, aneurysms, skull-based neurosurgery. And basically over the next 3 to 5 years, the senior guys let you go and you do more and more of the bigger cases, and then all of a sudden you become the guy for the bigger operations. So our host went down that pathway, and so he's the big guy in Hanoi, and he basically is the bypass and tumor guy. So we got there thinking we were gonna help him and teach him things that we knew in the U.S. And we found out that he's much more skilled and better than us in almost everything because his volume is through the roof. He's a wonderful guy. So it's also humbling in that regard when we go to different countries, thinking we're gonna teach them something, and we end up learning more from them. A couple of things. It was a fruitful endeavor to Vietnam. We published a couple of papers that I'll try to kind of briefly highlight there. We were able to go to Ha Long Bay, which was this beautiful portion of the world. But basically, through this, we worked with them. We did a social media poll, and I think that the faculty on this meeting will find it interesting that the Asian residents that worked the longest hours had the highest job satisfaction, where the European and American residents that worked the medium to least amount of hours had the lowest job satisfaction. I'll leave it as that. We can all come up with our reasons why we think that's true. And then we also did a ruptured AVM paper. So traditionally here in the US, ruptured AVM comes in, maybe you do a hemicrania, maybe you do an EVD, you let the AVM cool off, you do your diagnostic angiogram, you find the rupture point if it's associated with a prenatal aneurysm, and then you kind of take your time with the AVM. They don't have that ability to keep patients in the ICU for a prolonged period of time. That just does not exist. So for them, all AVMs that come in get dealt with acutely, which means they usually don't have an angiogram. They usually don't have embolization. It's a CT angiogram and straight to the OR. And we found that they get pretty good results for grade 1 and grade 2 AVMs that do present to their emergency room. I'll touch about this a little bit later, but because the EMS system is not as quick, by definition, you're going to see only grade 1 and grade 2 subarachnoid hemorrhages or good grade AVMs. You're not really going to see the higher grade subarachnoid hemorrhages or AVMs because they're probably going to pass before getting to the hospital. And so that is their experience with managing these patients. But it's an interesting thing. Whenever the hospital decides it's time to extubate, if the family wants to bag or trach the patient, the family member has to be at bedside bagging the patient. And so that really frames if the family will then proceed with the trach peg route. I think it would be very interesting if we did that here in the United States. I unfortunately wasn't able to go to Panama, but we went from Vietnam. We did Panama the following year due to Dr. Jean's connections with Panama. And basically, since essentially a single payer system, you have these end stage tumors that are presenting and just waiting to undergo surgery. So a lot of the surgeons, and it's very similar in the Philippines, they do the one case that's required for the day, and then they go to their private practice to actually make a living and be able to pay for things. And so you have a lot of these public hospital patients just are waiting for surgeries because it takes so long because of healthcare and whatnot and being able to get advanced imaging. You only see big tumors. There's no such thing as an unruptured aneurysm. That does not exist essentially in their vocabulary. And then you don't see like 1 or 2 millimeter, 2 centimeter meningiomas. You're going to see only Goombas. And so that's very interesting to see from a healthcare perspective. And then a lot of this, the biggest lesson we took from Panama is really involving family. You can imagine these type of tumors are fraught with complications, prolonged hospital stay. That's not to say that they can't get a good outcome, but there's going to be a while where they're probably going to be in the ICU for a period of time. And in Ghana, I found out if you do these type of surgeries, if the patient runs out of money to be able to pay for the hospital care, the surgeon has to cover the cost. So that also then determines which cases that you're going to try to do in a surgical perspective. And it's really trying to tailor your goal of surgery. Can you get a cure? Do they have access to radiation surgery? What's the follow-up going to be like? Are they okay with a shunt? Should we just shunt this person and then they can live their life? That way they can get in and out of the hospital and get a period of time. All of these are very tricky questions that should be discussed with the patient as best as you can, and involving family, always involving family with that decision making. So this is our first trip to Ghana. This is us at the teaching hospital, top left. This is us scrubbing in for our cases. A wonderful set of lessons. A lot of what we manage and think we do, it's because we're so comfortable with the medication management, anesthesia, post-op care. That's why we're willing to take on cases. So some things as simple as gel foam soaked in thrombin, Surgicel, all these hemostatics, Surgiflow, FlowSeal, things that we don't think about because we use 2-3 of these vials in surgery. It really makes a difference for these patients because otherwise they wouldn't manage or think about taking these patients on. Having a good light, good microscope, all things that we generally have access to, that makes a world of difference for these hospitals. So having hemostatics for pituitaries, even as the ENT is doing his approach, everything's oozing, or as soon as you open up the cell and open up the dura, generally you get that maybe some oozing and you decide to stop because you don't have blood available, you don't have hemostatics available. So we're able to get pretty good resections on these pituitaries because we had access to hemostatics. The top right was a cervical ependymoma in a child. And so this is fascinating from a decision standpoint from us. Do you take this on? Do you not take this on? No, none of the local neurosurgeons were willing to take this, so we felt it was reasonable for us to try. We did have neuromonitoring. How do you consent the family? Are they going to get better? Are they going to be worse? These are the ones where it's not uncommon to say, hey, we lost motors in the case. They didn't have access to radiation therapy or follow-up. So these are all things that we're thinking before we take on these cases, but we felt that if she had no other option, it was a reasonable thing for us to take on. So we were able to get a good resection in this case. There was transient weakness, but she was walking by hospital day 2, so we got very lucky with that one. This is a big atrial meningioma. We probably don't see these sizes as much anymore because we're catching them when they're smaller and smaller, but you take this type of case on when you have limited access to blood supply. There's no preoperative embolization. You don't have an MRA or MRB to kind of take a look at things, and you don't have ultrasonic aspiration. So this is just essentially loop cautery and going as quickly as you can. And so that's one of the things that I've gotten much more comfortable as we've gotten more and more to these countries taking out these big tumors. Again, we're seeing these tumors tend to be late stage. They're presenting already with relatively fixed deficits. Fresh out of a vascular fellowship, I got thrown into one thing that I embraced, not thrown into, was doing vascular cases in different countries. I honestly probably clip more during my my international rotations than I do in the U.S. But this was the first clipping in the country, not something that I aspired to, but just something that I fell into. So I accosted the cardiology cath lab to do these angiograms, getting these fairly beautiful pictures. You could see the aneurysms confirming, showing the local surgeons, residents, neurosurgeons that you can do these things on a cardiology suite lab, get images that are reasonable, fast, and efficient, and then clipping it. And so this is, we clipped 2 aneurysms our first go around. I'll talk about this a little bit later, but we're really trying to get the local neurosurgeons and attendings involved so that they can see, hey, we can do this in our country. They're very, very hungry for knowledge and for the experience. There's a lot of politics, as always, as you can imagine, even though you're just trying to do the best thing for the country and for the patient. And then not only was I able to clip the first aneurysm, I also got the first intraoperative rupture and how to manage that. So these are a couple cases that I'll go through just so you can see what we're trying to deal with. So a lot of these patients have previously ruptured. So they've ruptured within the last 2 years. Usually they've survived it. So by definition, they're almost always going to be a grade 1 or grade 2 subarachnoid hemorrhage, because the grade 3s and ups aren't going to survive the natural history course. In our first go around, it was a set cost, let's say $500 to do the angiogram, clipping, anesthesia, ICU care, postoperative angiogram. This is actually a brand new Philips machine, the single plane for the cardiac cath lab. I learned that there's software that you need to buy to be able to do a digital subtraction angiography and to do road mapping and smart masking kind of techniques. So that's something I learned by going to a different country. I thought they were all interchangeable. Answer to that is no. And then this was probably good, mostly for my own soul, but probably for the residents at the time. But I also got an intraoperative rupture during this PCOM, so they were able to see, okay, now I got my temp clips on, I got my large bore suction in there, do my pilot clip, investigate, make sure I'm communicating with anesthesia, and being able to handle that in an efficient manner. But it was good for them to see, because not only did we look like you will run into a ruptured aneurysm, or excuse me, into that intraoperative rupture, and we need to all be facile with being able to manage it. And then basically we were able to go to Ghana a couple of years, and I got more confident, and I'm half Filipino, so the neurosurgeon that treated my mother's aneurysm invited me to go back, and it was my first sort of experience as being sort of the visiting professor kind of deal. So they were able to invite me over. I went to the main teaching hospital, which was great. And then we went out into the provinces and did a bunch of, basically they used me as the diagnostic angiogram guy, because a lot of their patients can't get any angiograms whatsoever. So I was able to help them with that, and we did a bunch of cases. I show this slide because it's very interesting, because they didn't want to hear anything about hybrid neurosurgery. They didn't want to hear about endovascular AVMs, aneurysms. They're like, we just had Dr. Hanel over. We got a bunch of that. A lot of the neurosurgeons in the Philippines, that there's about 3 or 4 dual trained guys that got their training in Canada. So they're very, very facile, very, very good with endovascular stuff. So I asked, do you want to hear about MMA embo, because all the trials were coming out, and they're like, yeah, sure, let's talk about MMA embos, which I think everyone does maybe 1 or 2 a week, because it's such a common pathology. And I remember them asking me, going, why not just put a burr hole in that patient's head, because you're doing catheter, guide catheter, onyx, glue, particles, coils, and you're just sort of driving up the cost of the treatment. And they're like, burr holes work just as good as anything, and it's a junior residence case. They use the Hudson brace. There's not even an electric drill when they do these cases, and it's such a cost-efficient operation to just do a burr hole. It's just funny, interesting that that's the perspective, right? They don't need all these $20,000, $30,000, $40,000 procedures and things to do the subdural embolization. Same thing we talked about. We use a lot of ICP monitors. I have a neurointensivist that loves looking at PRXs for ischemic stroke, subarachnoid hemorrhages, vasospasm, on top of just TBI. And so I talked about that, and they were like, did the patient do any better or worse? And I was like, about the same as if we didn't put the bolt in and not have these PRXs. So it's a very interesting perspective on technology and the halves, and does it actually really make a difference? So this is a case they asked me to take care of for them. Giant ACOM aneurysm, bulbous, growing, and I remember doing this case, and I'm like, I think they're going to want me to trap the ACOM complex, open up the dome, suction out the clot. And I'm like, do I really want to do this as my visiting professor case? So I basically stacked a couple clips, and I looked at the neurosurgeon that was there with me. I'm like, if you want to get a perfect cure here, I'm going to hand the case off to you. And so he went in and he's like, yeah, we trap these type of aneurysms all the time. Had no problem getting clips on both A1s and A2s, opening up the dome, suctioning out the clot, and then clip reconstructing it. So whereas probably here in the U.S. we see this a lot less, this is sort of what they see a lot more over there. So it was a very good, humbling learning experience going back to the Philippines. The chief residents in the Philippines at the university hospital will clip 200 aneurysms before they graduate. So they're very facile with ruptured aneurysms before they leave, which is a lost art, especially in the U.S. Because they asked me, this is a 70, I think he was a 74, 75-year-old growing ACOM aneurysm. I was like, I'd probably stent coil this, subpack pack the aneurysm moderately, not go for broke, and then follow up with MRAs because he's old, which they got a good chuckle out of. These are the couple of cases that we did out in the province. This was the first ever balloon test occlusion there. They were planning to do a bypass with me leading the case. I was like, why don't we just do a BTO? Fortunately, the patient passed the BTO, and we were just able to do apparent artery occlusion on this. Lots of AVMs. They had a couple of AVMs. This is a 3-year-old with Moya syndrome that helped them do an indirect bypass on. That was interesting. And they had a couple of ruptured AVMs that I was able to go through with them. They had a couple meningiomas that I was able to embolize with PVA preoperatively. This was my first coiling of an aneurysm on a single plane without smart mask, which is a little harrowing. Thankfully, these are young patients with good arches and fairly visible anatomy. And as you can see, I didn't go for broke, just enough to get the dome protected, get 2-3 coils in, and that was my first last coil, as we like to say. And we did intradural extramedullary tumor here. A lot of these things are donations, so reach out to companies. After maybe 20 emails, somebody responds to me. This is actually from Dr. Marcos, who is donating these older alginoid clips from Mizuho. Whatever we don't use in the OR, I try to bring over. You can see here a lot of the Surgiflow, Flow Seal, hemostatic agents. The endovascular stuff is really expensive, so those are a little bit trickier to come with. They tend to reuse the endovascular equipment, so even getting the ones that we open but we don't actually use, I'll repurpose them for the trips. Microscope drapes, all the drills, right? Drills, bipolars, anything that's single use. I'll wash them in the sink and bring them with me, which they'll be sterilized in the country, particularly in Ghana. A lot of it is just being resourceful with what we have. This is a 15-year-old that ruptured 6 months a year before we showed up. This was initially read as negative, but we were like, hey, there's clearly an ICA terminus aneurysm there. If there's any doubt, we don't have access to the C-suite, the cath lab there, so we just use a C-arm. You can see we did a C-arm. And so it's helpful for getting these people to know, hey, there are things that we can do to help confirm our diagnosis and help us treat these patients. So we confirmed there that there is an ICA terminus, and we recommended clipping this aneurysm in a 15-year-old. A lot of these patients, we're looking in hard films, which I alluded to. Takes skill, I think, since it's a lost art. A lot of patients will get diagnosed with stroke, and then they don't get any advanced imaging till later. So this guy was thought to have a left MCA syndrome, and then it turned out he had a pretty large meningioma that we were able to remove. You can see over here there's a very large MCA bifurcation aneurysm that we recommended treatment. They have a lot of skull-based tumors that are presenting end stage. This was an acoustic that we'd recommended taking out. Unfortunately, the patient passed before we showed up. This is us. We're really trying to involve the local neurosurgeons, education, getting them up to speed, trying to get them comfortable, trying to get them microscope time, really trying to get them involved in the case. So this is the case where I had the intraop rupture, so they were able to see how to manage that, treat it, and still move on with the case safely. In Ghana, we've ended up being a private sector. The local neurosurgeons that are part of the university system are hesitant to have us be involved in their care. So fascinating enough, there's a prefix price for the surgeries, and so we've been doing them in the private system, which is interesting because then we have control of the ICUs for that day, we have control of the anesthesia and the operating rooms for that day. Rounds is great because the patients in the hospital are all hours, and we're able to talk to nursing, see the patients in the morning, see them in the afternoon in between cases, and then see them before they leave. Sometimes blood's available, sometimes it's not. We're clipping all these aneurysms without Mayfields. There's no ICG, there's no Doppler. We don't have fixed retractors, and the microscope's mostly working, and we don't have any neuromonitoring. So it really moves us out of our comfort zone when we do these cases. We really try to force a microscope. They do have a working microscope at the place that we're at. We were able to get Leica to donate a second microscope. So we have 2 microscopes in this private hospital. We were able to get 1 hospital microscope to the public hospital as well. Just so that they get repetitions over and over again. It's so much easier to do some things with just loops, but really it's the microscope that people need repetitions on. I'll talk about this skull base tumor that this is end stage, right? You can see the eyes proptotic. They've been blind for years. Do you even offer to do anything for these type of cases? And if you do, what kind of stuff do you do? So why am I blanking her name? But this is one of the Ghanaian neurosurgery residents. Her name's Irene, excuse me, and she's the first resident to clip an aneurysm, first female resident, first female neurosurgeon in Ghana to clip an aneurysm. So we're actually able to involve the local neurosurgery residents some of the times to be able to be involved in these cases. This is just more of a story to share with you guys. On our last day of our trip, a lady comes in with a bad headache, gets diagnosed with this giant ICH-terminus aneurysm. Unfortunately, it's the last 2 hours that we're going to be in the country. And the question is, what do you do for this type of patient? Do you let her be, cool off, and let natural history take its course, or you try? So this case, we tried to rush last minute, put her on the case. She has a blood pressure spike with induction, brain's all tense and full when we open up the dura. Fortunately, we were able to clip this aneurysm fairly quickly. We just did a floating type bone flap with sutures for the reconstruction. And this is us on the ambulance on the way to the hospital, giddy that we were able to do this type of case. Unfortunately, she made a very good outcome, and we made her flight home. This is her at 1 year. So she has that facial asymmetry, a little weakness, but fortunately did very well. And we were lucky that we were able to do that surgery for her. I'm not sure if the video will work, but this is a similar case. What do you do for these cases? We thought we were doing her a favor. Because mesis was her biggest concern, so we did sort of this orbitotomy, lateral approach, decompress the orbit, roof of the orbit, allow skull base, improve the mesis of this lady. We didn't really chase after this lateral cavernous stuff because we were like, we were not really going to be helping her. And then basically she did great, got good cosmetic outcome. And then on our 3rd trip, 2 years later, basically the video will play. But basically the tumor is now eroded more laterally and going posterior along the tent, going down to the brainstem. And so it's one of these things. Should we have done the first surgery, or are we really making an outcome here? Should we have been more aggressive the first go around, knowing that there's no radiation, or did we do the right thing? We just did what we could at the time, and that's sort of what we get. Post-op complication management is pretty important here. We try to do the cases that we're most worried about, CSF leaks and healing first, that if there's anything bad, we can take care of it at the end of the day. A lot of times it's very humbling. We think we did something right, and then 2 years later, 3 years later, when we come back, we ask the host neurosurgeon, how's that lady doing? And he's like, oh, she came back, she got infected and had to go to New York and had surgery done in New York. So that was one of the cases we did that we thought we did the right thing on. Again, it's using a lot of autologous stuff, doing very good pericranial harvesting, finding fasciolata, using fat to plug in leaks and holes after taking out these tumors. During our last trip, I don't know why, but we felt the need to do eyebrow approaches for ACOM aneurysms. These are a couple of the cases that we did. Fortunately, they did very well. One of them developed a pseudomeningocele that the local guy was able to go back and just put some Tacocele and use to plug up the hole that we did. But it's fascinating. These are the CAT scans that we see, and we're like, is this patient alive? Don't they have a shunt in? And they're walking into our clinic having full conversations with us. This is one of the cases we did. We're walking one of the residents who's never done anything endonasal. Of course, as soon as he gets into tumor, we get immediate CSF, and then we've now had to take over the case to take out the tumor plus manage the CSF leak. But I think that's something worth discussing. Lumbar drain, fat graft, all of that should be well discussed ahead of time. And then this patient ended up leaking post-op day 2 or day 3, so I had to take him back to repair our CSF leak. But all of that needs to be planned out, especially if the local hosts may not be comfortable managing with the leaks that are associated with these types of operations. These are some of the cases that we did. This ended up being a schwannoma. Again, they're presenting, these are very late stage. You're looking at hard films. I show this because one of the residents brought up the concept, like, how do you know this isn't a giant partially thrombosed aneurysm? With this video, we're intraoperative C-arm angiogram, just to confirm, hey, there's no surprise here. It's the MCA candelabra is pushed up over here. Again, they get to see that we're using the technology and resources at hand. This is I'll try to hurry up here. Parathalassine meningioma. We don't have any vascular imaging to see if the sinus is open, and so we used our C-arm technology. These are our fiducials, are the EKG leads. This is us doing the angiogram over here, and then you can see not the greatest clarity over here, but we were able to decide if the sinus is patent or not. I think this one was occluded, and then we can look at the EKG leads to see where our incision needs to be. So a lot of information you can gain from a single vessel angiogram. I show this case because this is probably one of the more humbling cases. Essentially, you can see the left eye is non-functional, starting to get compromised vision in the right eye. She is 10 years old at the time, and we're like, what are we doing here? Should we take this out? None of the local neurosurgeons would take this out, so we felt it was reasonable for us to attempt to try. What surgery are we going to do? How are we going to reconstruct things? Do we go for broke? All these things come into our mind as we're doing this. So it ended up being a mucocele. Fortunately for her, that's what it was. That's what the path came back was. There was some infection. We repaired the skull-base defect. This is us sort of going, what are we going to do for this kid in the pre-op holding area, trying to decide, should we do a transfacial approach, which none of us have actually done. Is now the time for us to do this type of case? What of a correction are we going to get? Because she's pre-puberty and all the suture lines and all that none of us think about anymore. So we did a bifrontal, we took out the mucocele. Of course, she got a leak, but fortunately we were able to repair that before we left, and she's doing just fine. And then this is a similar case, these big proptotic frontal-orbital meningiomas. Should we be going after more of the tumor, or should we just be trying to get cosmesis? For this lady, we just did cosmesis. This is actually a very clear classic trigeminal neuralgia patient who was ecstatic that we were able to do the surgery, but it's good anatomy for the residents, the local neurosurgeon, that you can do these type of pain operations quickly, safely, and efficiently. We really tried to do formal courses. This is us trying to do courses for education, Zoom meetings ahead of time, trying to plan and teach the local neurosurgery residency population. We've gone to several radio stations and TV stations, just try to show, advocate, and educate the local Ghanaian population. Again, just trying to show them videos, clips, debriefs, going through the cases that we did ahead of time after the surgery, making sure we talk to them about complications. And really, there's a lot of politics that I've learned more and more. It varies between countries and neurosurgeons. Doesn't matter what your intentions are, but there's always politics and who will come and help and which residents will participate. at least in Ghana, we found that the private hospital system has been very open to us. We're able to do the surgery safely, efficiently, well. They get a good price for the procedure. Whereas in the public health system, they haven't been open to us helping them in doing cases there, despite our attempts to try to be involved in the educational system. We turned down a fair amount of the cases. This is a vein of Galen malformation. They made it seem like this patient had a MCA stenosis or aneurysm, and I was like, this isn't a stroke. But just looking at the films and evaluating them, do you go after Spetzer Martin 3 AVMs there where you may not have blood in a deep location? Those are the type of stuff that we turn down. This is a lady that has aneurysms in every blood vessel, as you can see here. The valves are both carotid arteries are giant ectatic aneurysms. This is a picture from residency. People may recognize Dr. Armada showing us how to clip aneurysms using a resident's neck. Same thing, here we are at dinner looking at the forks and spoons, using it to be our circle of Willis to look at these aneurysms. This is a case that I show, if you can see the video. It's a 15-year-old with a tumor. Unfortunately, we really wanted to crash this patient to surgery, and that's where we learned the host neurosurgeon ends up footing the bill if the patient isn't able to leave the hospital. So we had to let that one go because the family couldn't afford the surgery. Just wrapping things up, everybody's so wonderful. Everybody's so open and hungry for education and knowledge and these little missions that I've been available to be part of. We're trying to really get the residents. I think 3 residents or 4 residents have now clipped aneurysms through our mission trips over there. I don't know the best way of checking outcomes, to be honest with ourselves. So I have a spreadsheet. We've done about 50 cases. We've probably had about 3 mortalities from the cases that we've done. For the most part, I think we've gotten good outcomes, and the patients have done well and have benefited from our medical mission trips. So just to close things, planning is always good. Zoom meetings have, because of the pandemic, have allowed us to plan things a little bit better. Patients that may pass away, they may get cold feet, they may not be able to afford the surgery. Things change frequently. About half the cases we plan on, about maybe we see 20 cases, we're going to say, hey, let's do all 20 of these cases. We end up doing 10 cases at the time of the trip, of which 5 pop up along the way through social media and whatnot while we're in the country. So it's a little bit frustrating, but that makes it a little bit more exciting. We try to involve residents as much as we can, teach, debrief, make sure that they know what we were thinking, indications, and that complications should be part of the thought processes. Knowing your OR resources, PACU, ICU, rehab, ventilator support. Each country has their own pathway and long-term management of these patients and what the society deems is appropriate. And so this is the young lady that we did, and these are my 2 girls. We're going to Ethiopia in February, as we're going to like our 4th or 5th country now. And that's all I got. I'll take any questions if there's any.
Thank you, Rudy. That was wonderful. We do have a few questions. The first one is, what has your success rate been in training the neurosurgeons abroad in terms of now they feel comfortable doing the cases and you no longer have to go to those hospitals because you've trained them up and they feel comfortable?
So Vietnam, the guy was much more talented than I'll ever be. So I think they get appropriate training. It's just that most don't want to do skull-based or aneurysm surgeries. Panama, a lot of them get pretty good training. It's just resources in the country, and do they really want to keep doing these 6 to 8 hour cases? Ghana, so far, the full neurosurgeon over there has scrubbed a bunch of our cases. It's just so tricky doing 2 cases once a year for 3 years. Is that enough for you to say, hey, I'm willing to clip an aneurysm? So I don't think they're quite there yet, especially because like the assistant scope doesn't always work. So it's hard for you to teach and say this is the right thing and the not thing. So I would unfortunately say that they're not comfortable yet with aneurysms. At the last talk that educational seminar that we did, they do about 5 turionos a year. They just don't have access to microscopes. So they just don't go after the deeper stuff. And then if you can't get the microsurgical practice, then it's hard to then say, I'm going to clip an aneurysm.
Yeah. And you mentioned that there's no blood available. Is that everywhere you go, there's no blood bank or blood supply?
So Ghana has been good, but they might have 1 unit or 2 units, not a whole lot. Same thing in the Philippines. They have some, not a lot. And so there's usually resources. We usually insist on making sure there's some of that available before we take on, especially like the parathalassine meningioma that's non-embolized, we want to make sure that there's blood available. But sometimes they don't. One of those aneurysms that we didn't have blood available because she just showed up that day.
Mm. How have you applied what you have learned to your practice in DC?
I'm just much more thankful for all the resources that I have. I'm much more patient as a human being, I think, going from there and then coming back. I think I'm more willing to have conversations, difficult conversations with family, like, what are we really doing here? Should we be doing this on the 90-year-old person? Is this really what we should be doing? So I think it's allowed me to be a little bit more frank or honest with conversations with families for indications for surgeries. Like the degenerative spine conversation, it's just such a different conversation than these conversations we're having. So I think it's changed the way I talk to patients and manage them.
Do you notice they're receptive to that? Like, are the patients here realistic to that or
No,
no?
no, they're not, but I try.
All right. And then I don't see any additional questions on the chat, but that was excellent. And thank you so much for joining us. I
Thanks for
really
having me. Thanks for training me.
thought that was
I
interesting.
always have your voice in my head when I'm doing these cases.
I see Dr. Vez and Lehman are on as well, so I'm sure that they're in your head as well.
Of course.
All right. Thank you so much.
Thank you.
All
Take care,
right.
guys.
Bye.